Thank you, sir. Good afternoon, everyone. So in this rapid review, I'll be covering abstracts on supportive care. There are 4 in the field of cardiotoxicity, 2 for neurotoxicity. There's one on a risk score for chemotherapy in the elderly. There's one on lifestyle intervention and effect on disease-free survival in early breast cancer. Then use of hormone replacement therapy in BRCA carriers. Meta-analysis of the fertility preservation with GnRH agonists, and finally something on bone-modifying agents. So the first abstract, and I've decided to start with the cardiology ones first, is cardiovascular disease incidence after internal mammary chain radiation and anthracycline-based chemotherapy for breast cancer. This was published in August 2018 by the Netherlands group in the British Journal of Cancer. So, as recent trials have shown an improved breast cancer-specific survival, the role of internal mammary radiation has been revisited and revived. Many of these patients have also received anthracyclines. So what this study did was reported separate and combined effects of fields of radiotherapy, different types of chemotherapy, and cardiovascular risk factors on long-term ischemic heart disease, valvular heart disease, and heart failure in breast cancer patients below 62 years. And these are the results that you can see. So basically what they did was they looked at the comparison of myocardial infarction and heart failure rates among the general population. So as you can see, in those patients that received internal mammary chain radiation had a higher risk of myocardial infarct as well as heart failure. And then they looked at the various regimens which were used, and compared to the general population, the use of anthracyclines, as expected, led to a much higher standardized incidence ratio of heart failure. If you look at the table below, this was a within-cohort comparison of cardiovascular disease rates after breast cancer by treatment. And if you look uniformly, when the internal mammary chain radiation was given, there was a higher risk of ischemic heart disease, valvular heart disease, and heart failure. And again, if you look at the joint effects of treatment, when IMC, that is internal mammary chain radiation, was combined with anthracyclines, it led to a much higher incidence of cardiovascular events. These results are relevant to breast cancer survivors who've been treated with older regimens. Today, we don't go up to those high doses of 13 gray. We usually use 7 to 8 gray. The limitations in this study are patients on trastuzumab and taxane were not included. And it, of course, suggests that combined effects of radiation and anthracycline are greater than individual effects. The second abstract is something we all deal with in general practice, the long-term adjuvant endocrine therapy and risk of cardiovascular disease in female survivors, and this was a systematic review published in BMJ. So what is already known is that we have several meta-analyses on the adjuvant treatment of breast cancer with endocrine therapy and the risk of composite cardiovascular outcomes, but we don't know the range of clinically specific cardiovascular diseases which might be affected with this endocrine therapy. And a lot of meta-analyses have not taken into account the observational studies which reflect the real-life setting. So this is a little busy, and I don't expect you to read it in detail. So what basically they showed is whether you look at myocardial infarction, whether you look at stroke, or whether you look at angina, which are all arterial events, the aromatase inhibitors appear to do worse, and there is a protective effect seen with tamoxifen. That's all this graph shows. And coming to the venous events like thromboembolism, naturally tamoxifen is worse and the aromatase inhibitors are better. So 26 studies were identified for 7 conditions, and although there is an increased risk of venous events for tamoxifen users, there is a higher risk of vascular arterial events such as MI and angina in AI users, but this could be also partly driven due to the protective effect of tamoxifen in this group. But what they concluded was that don't only look at the usage of AIs and tamoxifen based on disease recurrence rates. also take into account the risk of the patient for venous or arterial disease before choosing the right endocrine therapy. Third abstract is the current guidelines and future directions of cardiovascular toxicity in survivors. And we know that these toxicities represent a leading cause of mortality and morbidity, and these occur 10 years after the cancer diagnosis. There's been a recent study of patients enrolled in the SWOG trials, and they've looked and found that cardiovascular disease is an important cause of all-cause mortality in these patients. So this review examines the current guidelines which are available to address the management of patients related to cardiotoxicity amongst survivors, looks at the similarities and differences. So these are the different reviews which were compared in the paper. You had data from the International Society of Geriatric Oncology, ESMO, the American Society of Echocardiography, and the NCCN. And whereas you can see that they agreed on identifying risk factors pre-treatment, they had different views on the use of cardiac biomarkers and imaging. As far as the COG went, in elderly patients, it makes sense to do a 2D echo every 2 to 3 cycles of anthracyclines, and all did not agree on the prophylactic use of beta blockers or ACE inhibitors, and of course, all universally agreed that a cardiology reference is very, very important in managing these survivors. The fourth abstract is on risk-age mismatch, risk imaging mismatch in cardiac imaging practices for women receiving systemic therapy for EBC. So what is the cardiac imaging practice and how do you monitor it with relation to heart failure risk? This is a prospective-based retrospective cohort study from Canada, and they looked at the proportion of patients that underwent imaging and what was their incidence of major adverse cardiac events or MACE rates. And this was based on the regimen patients received and the heart failure risk factors. And what you can see is, if you look, this is the patients who received baseline imaging, and it was pretty interesting that in those that received anthracyclines alone, it was patients who had a heart failure risk factor, at least one or more, that led to even more baseline imaging compared to no risk factors. But uniformly, when patients were considered for trastuzumab, a very, very high percentage of them received baseline cardiac imaging. If we look at the 5-year cumulative incidence of MACE, you can see clearly that the presence of these risk factors conferred a higher risk, whether it was anthracycline or trastuzumab, of major cardiac events. So baseline cardiac imaging practice varies very variable according to the treatment that is used. And of course, patients who have these cardiac risk factors are at a very high risk for major cardiac events. We now turn our attention to peripheral neuropathy. There are 2 very interesting abstracts. This, in fact, was a 2-year trend of taxane-induced neuropathy in women enrolled in a trial of acetyl L-carnitine from the SWOG study. And this was reported in the Journal of NCI. We know chemo is a disabling side effect of taxanes, causes bad peripheral neuropathy, and a previous study just showed that ALC or acetyl L-carnitine, which is nothing but a mitochondrial booster, acts like an antioxidant, just unexpectedly increased the incidence of neuropathy. So CPIN was measured by a FACT taxane scale at regular intervals. These patients received the supplement for 24 weeks. The other group did not receive the supplement at all, and they totally evaluated 409 patients. Now, as you can see here, the red line reflects the placebo. The blue line reflects the patients who received the supplement for 24 weeks. And at each, and this is the baseline neurotoxicity score, both groups had a deterioration. But in the group that received the supplement, it was consistently compromised. So basically, the conclusion was that these scores were reduced from baseline and remained persistently low. And the supplement therapy not only led to bad neuropathy, but this continued for a period of 2 years. And we don't know the mechanism why this happens, but until we do, it is not recommended to just ad hoc add supplements like, we give glutamine and we give antioxidants to these patients, thinking it will mitigate their symptoms, but in fact, we could be doing harm in this setting. The next abstract on neuropathy is a sub-study from the CALGB 40101, and they correlated age and risk of paclitaxel neuropathy in these women. So the study background was single-agent paclitaxel versus AC to prove non-inferiority. This trial did not meet its endpoint, and in fact, AC was superior in patients with 0 to 3 nodes positive. Pacli in this study was given as a weekly or a two-weekly regimen, and the incidence and severity of neuropathy was studied in patients more than 65 years of age, between 55 and 64, and less than 55. Over 1,800 women were eligible, and grade 2 or worse neuropathy was found in 27, 28, and 24% of these 3 age groups, so it did not differ according to the age. Only motor neuropathy had a higher incidence, but this was not confirmed in the multivariate analysis. The time to onset and improvement also showed no age-based differences, but in contrast, obesity and 2-weekly Pacli was associated with a trend towards neuropathy. Therefore, old age is not a risk factor. You don't need to be worried if your patient is not a diabetic and has no other risk factors. It is safe to consider paclitaxel in these patients. The next, which I found extremely interesting, this was presented at San Antonio this year, was based on lifestyle intervention and effect on disease-free survival in early breast cancer. And the study was an open label one. The first randomization was compared chemo regimens, and second was for lifestyle intervention. In that group, patients received structured programs by telephone and mail to help lose weight and improve their diet. And those in the non-intervention group received just generalized recommendations. And amongst evaluable patients, the intervention program resulted in a weight loss of 1 kilo compared with a weight gain in the non-intervention group. But there was no difference with regard to disease-free survival or overall survival. Then they went back and they tried to look at patients who had actually completed the intervention program. And they found only 2/3 of these patients had actually completed it. And then they did an exploratory unplanned. Remember, this is an unplanned analysis of these completers. So with regard to weight loss, there was a significant difference amongst the completers. They lost far more weight, but there was similar weight gain seen in non-completers of both groups. Strangely enough, disease-free survival was significantly better amongst the completers, as was the overall survival. And when they did a multivariate analysis of these completers, remember it's exploratory, you had got a hazard ratio of 0.5. That is a 50% risk of reduction in mortality just by following or completing the intervention program. The question then arises is, are those the ones who completed the program, were those the fitter patients? And was this nothing but a reflection of the healthy participant effect? The next abstract is a very intriguing one, published in JAMA Oncology this year, and this was on hormone replacement therapy after oophorectomy in BRCA1 mutation carriers. So they wanted to look at how safe HRT is in this group of patients. So they had a large cohort of patients and the median follow-up of over 7 years. And these patients were all below 45 and had all had oophorectomy. They were not patients, they were carriers of BRCA1 and BRCA2. And they did a follow-up questionnaire to get detailed history of HRT use. And the main outcome measured was incident breast cancer. And overall, you can see that the use of estrogen after oophorectomy did not increase the risk, but patients who had combined progesterone and estrogen showed an increased risk of breast cancer, almost double that to estrogen alone. This is a meta-analysis of GnRH agonists, over 800 patients studied. As you can see, it is definitely better at preventing a premature ovarian insufficiency and increased pregnancy rate, irrespective of the trial, irrespective across patient groups. This is a very nice toxicity score developed for older women who receive chemotherapy with breast cancer. It comes from the CARG score, which is already available. So you add in information like anthracycline, abnormal liver function, and you develop a score. And this score was first developed, and you have 3 groups, low, medium, high. And then it has been validated in different cohorts, compares very well to performance status. So it can be used as adjuvant decision making. Then, of course, you have the 2 studies, and I'll just finish in a minute. The impact of denosumab. There were 2 trials published at ASCO this year, one following the other. One was a negative trial. The other was a positive trial. They were a little different in their patient groups. So the first was the ABCSG group. Earlier, they showed that this denosumab reduced skeletal-related events. Not only that, it showed it also improved disease-free survival in patients that got it versus placebo. But it was a very, very low-risk population and a very gentle regimen, and the biggest reduction was in second non-breast primary. So is this relevant, and should we be using it in this setting? The next study was a negative study by Coleman and his group, the DCARE study. They had a relatively higher risk population, a more intensive denosumab regimen, and they failed to show any improvement in bone metastasis or disease-free survival. And the end result and the discussion that took place after these 2 studies were that zoledronate is still the most important drug in the adjuvant setting for preventing osteoporosis, and has been consistently shown to have some disease-free survival benefit. Thank you.